Hello people, in this video we want to look at thyroid eye disease. So we will be covering all these things in this video. So thyroid eye disease is also called as TED. Where is thyroid, guys? Yes, it is here. And where are the eyes? Here. So what is this thyroid eye disease? So thyroid eye disease, three things they're telling: lid retracted, lids are retracted, lid lag, and proptosis. So you can look, it looks like as though he's staring because the lids are totally retracted. It won't close properly, the lids, right? Lid lag and proptosis. These three you have to remember. So thyroid eye disease is also called as all these things. Endocrine exophthalmos. See, exophthalmos means what? Exophthalmos is a type of proptosis because if it is because of thyroid, I think they're using this term, right? Exophthalmos. So it is endocrine exophthalmos, malignant exophthalmos, dysthyroid. Okay, dysthyroid we can understand. Dysthyroid ophthalmology. Ocular Graeve's disease. Graeve's disease, you know, right? And this is ocular part of that Graeve's disease, is it? Graeve's ophthalmology. Thyroid associated ophthalmology. Thyroid associated of the same name, same condition, a lot of names. Okay. Now, what are the risk factors? Females are more affected. Smoking, middle age. Oh, this is something that occurs in middle age. Okay. Autoimmune thyroid disease. These are the risk factors. If somebody has an autoimmune thyroid disease, HLA, DR3, HLA, B8. That means if these people have these genes or what. So these are the risk factors. People who have autoimmune thyroid disease, etc. And if you are middle aged. Interesting. Now, pathogenesis, actually what is happening, let us look at, okay? In pathogenesis, what they are saying is there is somebody who's targeting the orbital fibroblasts and the extraocular muscle. Who are those? Some antibody, some autoimmune condition is targeting the orbital fibroblasts. So let us say this is the orbit. You have the fibroblasts here. The orbital fibroblasts are being attacked. The extraocular muscles are being attacked. By whom? By some autoimmune process. So they are thinking that, see, they are still probable only, they are saying it is probable that the antigen is shared between the thyroid follicles and the orbital fibroblasts. So they are thinking that there is something common between the eye and the thyroid, and there is some antibody which actually is attacking thyroid and the eye. So there is something like that. Okay, guys, we are looking at pathogenesis. What are we looking at? Pathogenesis. Yes, pathogenesis of thyroid eye disease. What did we see so far? There is some antibody which is attacking the orbital fibroblast. First, initially it's attacking the orbital fibroblast, and secondary it is attacking the extraocular muscles. But the same antibody is also attacking, seems to be attacking the thyroid. So thyroid and eye both are being attacked by this antibody. Now, now there are some T cells which are activated, and because of this, what is happening? There is adipogenesis. Adipogenesis means fat, is it? Adipogenesis. Then fibroblast proliferation. Fibroblasts are becoming more or something, and there is glycosaminoglycans synthesis. So all these are increasing. There is stimulation of adipogenesis, fibroblast proliferation, glycosaminoglycan synthesis. As a consequence, what happens? Read here now. Extraocular muscles are going to become fat. They're going to have edema. The extraocular muscles are affected. See, first what was affected? Mainly you focus here. First the fibroblast. Second only it is affecting the extraocular muscles that you can see here. All of them are going edema. Okay, and the orbit shows increased amount of mucopolysaccharides, infiltration of lymphocytes, plasma cells, and something else is there here, macrophages. So all that is happening. Okay, so you understood, right? In pathogenesis, what did we read? There is some antibody. Okay, this antibody is attacking whom and all? The eye and the thyroid. We are looking at what happens in the eye. In the eye, what is happening? It is attacking the fibroblast. After that, it is attacking because as a consequence of all that, secondarily what is getting affected? Extraocular muscles. Okay. So this is the histology of thyroid. If you remember, you would have seen in histology. This is how thyroid looks under microscope. Okay, we're done with pathogenesis. So where are we? Let's take a check. So we are here. We finished introduction, etiology. Introduction we saw it is, what did we see? Three things we saw. What is there? Lid retraction, lid lag, proptosis. Etiology, we saw that the cause is thyroid, either hyperthyroidism or euthyroid itself. Risk factors, what did we see? Female, then middle age, then autoimmune thyroid disease if they have. And what else did we see? Pathogenesis, mainly we saw the antibodies will first, it seems to be shared between the thyroid and the eye. First it will attack the fibroblasts or ocular, then it will attack the extraocular muscles. And now we'll move to clinical profile. Let us see what the clinical features are. You have to look at the lids. We already know it will be retracted, lid lag, this already we know. Conjunctiva, some deep infection, chemosis will be there, infection, okay? So, sorry, injection, sorry, not infection, deep injection. Let's see, then pupillary, what will you see? Dilation, unequal dilation of pupils. Ocular motility defects, he cannot move the eyes properly because extraocular muscles are involved, right? Exophthalmos, yes, that proptosis because of thyroid eye disease, exophthalmos. So it looks like the eyes are popping out, right? It looks like the person is staring because of all this lid retraction. Guys, unilateral proptosis is also possible. Now here comes the challenge for you. What is the challenge? Tell these names. What is this Dalrymple's sign? Von Graeffe's sign? Enroth's sign? Gifford's sign? Stellwag's sign? All these names you have to write if you want marks. What is it? Dalrymple's sign. Staring, frightened appearance, staring. Von Graeffe's sign, lid lag. When the globe is moved downward, the upper lid lags behind. Then Enroth sign, fullness of eyelids due to puffy oedematous swelling. Eyelids itself are full, is it? They look full, okay. Gifford's sign, difficulty in eversion of upper eyelid. You try to take the upper eyelid and evert, no, it's difficult. Gifford sign. Stellwag's sign, infrequent blinking. These people don't blink. See, they're staring. They don't blink so often. Infrequent blinking. You cannot evert the upper eyelid. Gifford. Enroth, fullness. Von Graefe kind of sign. Von Graeffe's sign. When the globe is moved downwards, the upper eyelid cannot come down. Just like the giraffe's neck, it is so high up, it cannot come down. Von Graefe sign you can remember. Dalrymple's sign. This Dalrymple is really staring at you. Dalrymple's sign. Okay guys, you have to remember all these signs, okay? Let's move on. Pupillary signs we already saw, inequality of dilation of pupils. It's of less importance, they are saying. Ocular motility defects can be there. That is Mobius sign. Okay, we can remember this. Mobility, motility, something like that. The range from convergence weakness to partial or incomplete immobility of extrinsic ocular muscles. Mobius sign. There's another sign here, guys. Mobius sign. Are you paying attention? What are we looking at? We are looking at the clinical features of thyroid eye disease. Okay. Exophthalmos. They didn't give any sign name for this. Okay. So, can you tell the names of all the signs? Dalrymple, Von Graefe, Enroth, Gifford. Okay. All these signs are there. Okay. Let's move on. Still some more signs are there. Exposure keratitis. Because the eyes are open so much, right? Obviously, there's exposure and dryness, and exposure keratitis can be there. Lagophthalmos, inability to elevate the eye and decrease blink rate. We already saw that is decreased blink rate. Optic neuropathy occurs in about 60% of the cases. So there can be optic neuropathy. Now their optic nerve also is gone, is it? Going. Their optic nerve also is getting damaged, is it? They manifest as papilloedema, optic atrophy associated with slowly progressive impairment of vision. Okay, because of compression of the nerve, direct compression of the nerve and or its blood vessel. So the blood vessel supplying the nerve is also damaged. So nerves are compressed means optic neuropathy, obviously. So they can lose vision. Because of all that edema inside, right? They were talking about that. The muscles are edematous. So much of pressure inside, fibroblasts, proliferation, macrophages, everything entered. And there is pressure on the nerve and it can go into optic neuropathy. So can you tell the clinical features? So we have to go to classification now, guys. We're done with clinical profile. Clinical profile, what and all we saw? Lid. Some signs we saw of lid. Then we saw conjunctival signs. Then we saw cornea. What was there? Exposure keratitis and all that. Then there was, come on, you can say, exophthalmos was there. Then what else was there? Hold on. Let's try to recollect. Pupillary signs, motility defects. Pupillary signs, motility defects, and then let's add pupillary sign, motility defects, because of which they can have diplopia, right? Did I forget anything else? Oh yeah, optic neuropathy. All these are the clinical profile. Now let's move on to classification, guys. Okay, let's go to classification. American Thyroid Association has classified Graefe ophthalmology. Irrespective of the hormonal status, it is NOSPECS. Some acronym is NOSPECS. Let's look at this. NOSPECS. Class 0 to class 6 is there. 1, 2, 3, 4, 5, 6, 7. That means 7 phases, right? Because there is class 0 to class 6. But anyway, 0 is no signs and symptoms. Then what is there to make it class 0? Okay, he has no signs and symptoms. Let's make that green then. Then let's come to the highest one, class 6. Slight loss due to optic nerve involvement with disc pallor or papilloedema and visual field defects. If it is slight loss itself, if they are saying class 6, then if there is major loss, then what do they call it? So this is for Graefe ophthalmology, is it? Classification for Graefe ophthalmology. So no signs and symptoms and loss of vision, optic nerve involvement. Then class 1 only signs, no symptoms. That means the patient is fine, but you are seeing signs. Class 2 is soft tissue involvement with signs. So S. Then P, proptosis. Proptosis, again here it is not a, it's more like a sign, right? Proptosis is well established. Patient may complain of same though. Class 4 is extraocular muscles are involved. Extraocular muscles are involved. So when there is limitation of the movement, what will happen? The person can have double vision, diplopia, etc. So did you get the Graefe ophthalmology classification? 0, 1, 2, 3, 4, 5, and 6. No specs. NOSPECS. N is no signs and symptoms. Then, what is this? Only signs you will see. Soft tissue involvement, signs. Then proptosis is well established. Extraocular muscles are involved, diplopia. What is C? Is there a C in that? Corneal involvement, exposure keratitis, and slight loss due to optic nerve involvement. Okay. We're done with classification, guys. Classification over. Now let us go to clinical course. Guys, are you paying attention? How's it going? What did we finish? Classification. What do we want to look at? Clinical course. Okay. How this disease progresses, is it? It's a self-limiting disease. This is what is so confusing. It limits itself, is it? How? It got tired of attacking the eye, is it? It lasts for 1 to 5 years, longer in smokers, obviously, yes. Clinical course is divided into 2 phases. There are 2 phases. Active phase, sorry. Go back. Yeah, active phase is there and inactive phase is there. So what is this active phase? Increasing severity, active inflammation, edema, conjunctival chemosis, exophthalmos, increasing. Everything is increasing. But then it starts regressing. Then there is fibrotic or inactive phase, quiescent, burnt out phase, the regression phase. Yeah, ensures this comes when after the regression. So in between these two, what will be there? There will be regression. Okay, so there are 2 phases, guys. What are the 2 phases? Active, inactive. That's it. Active. Then it will go into regression, which we are not giving as a active. Then there will be a regression. And then it will become fibrotic or inactive. Okay. Let's just see what we have finished so far. We saw introduction. What are the 3 things? Guys, come on, say the 3 things are lid lag, lid retraction, and proptosis. Etiology, we saw hyperthyroidism 90% of the cases. Risk factors will be female, middle age, etc. Pathogenesis will be that antibodies which are common to thyroid and eye, and it start attacking the eye muscles, the fibroblasts first and then the eye muscles. Clinical profile, you saw lid retraction, so many signs we saw. Then conjunctival chemosis, something cornea abrasions. This is actually stage 5, right? So corneal, keratitis, sorry. corneal exposure keratitis becomes stage 5 actually, right? Class 5 or something. So let's put that in the end only. Then you have diplopia, etc. And then cornea exposure keratitis. Exposure keratitis, that is class 5 or something, right? Then you have optic neuropathy, which is class 6. Then we saw classification. Then we also saw the clinical course, active, regressive, inactive. So in the classification, class 5 was corneal involvement, exposure keratitis. Yes, let's move on to diagnosis, investigations and management, guys. This is what we have to look at now. Let's look at diagnosis. How will you diagnose? It's not difficult with the advanced cases. It's not difficult, okay? And that too, if they have bilateral proptosis, you can see they're staring kind of an image. They won't blink much. However, if it is unilateral proptosis, you need to differentiate it from other unilateral proptosis. See, unilateral proptosis can happen because of congenital conditions, traumatic lesions, inflammatory lesions, circulatory disturbances, cysts in the orbit, tumors in the orbit, mucocele of the paranasal sinuses, etc. So there are a lot of causes. And if it is unilateral, it's difficult to diagnose. You'll have to differentiate it from other conditions, etc., etc. Now let's move on to investigations. What and all you will order? You'll order a thyroid function check test to check their thyroid levels. You will check what and all T3, T4, TSH, all that you can do. Then you will check the radioactive iodine uptake, right? How much of radioactivity is there. Then you will check the antibodies. Main thing here you focus is these antibodies. You want to check, are there any antibodies that are attacking the thyroid and the eye? We are concerned about that, right? So these antibodies could be so many. You cannot check one. You can check whether they are antibodies against TSH receptors. Are they anti-thyroperoxidase antibodies? Are there anti-thyroglobulin antibodies? Thyroid stimulating antibodies? Or ulta, are they stimulating the thyroid? So thyroid stimulating antibodies itself will create the hyperthyroidism, isn't it? That is what is bad for us. Everything else could be causing a hypothyroidism case. Anyways. So then you can do ultrasound also, and you can check increase in the size of the muscle thickness. Are you talking about the orbit or the thyroid ultrasound? It looks like extraocular. For the eye, they are doing some ultrasound, okay? And then they are doing computerized tomography scanning of what? Again of the eye, because here they're talking about proptosis and thickening of optic nerve, and also again they're talking about the eyes CT scan. Then they are doing the MRI. Okay, so MRI of what are they doing? Of the eye, is it? So CT is of the eye means MRI also could be of the eye only. So the first two tests, whatever they have mentioned here, are for the thyroid, guys. Thyroid. But the remaining three, ultrasound, CT and MRI, they're mentioning for the eye here. Okay. So that was about the investigations. Are there more investigations? No. We're done with investigations. Investigations done. Next we have to go to management. Let's go to the management. In management, three headings are there. Periodic clinical workup, non-surgical, surgical. Let's look at the management. Periodic clinical workup, this one. So basically, you will be looking at your these things every time. You will be looking at and you will be checking. Okay, periodically you will be checking and decide the treatment required. What and all you will be checking? Pain, redness, swelling, loss of function. Is their movement of the eye decreasing? Is their vision decreasing? All this you have to keep monitoring. Okay, what and all will you check? Pain, redness, swelling, and loss of function. All this you have to periodically, you have to keep checking to decide the treatment required, and you have to monitor the effect of the therapy. Periodically clinical workup also of the ocular motility, movement of the eyes also you will check. Hess-Lees chart to decide the intervention required. Hess-Lees chart you have seen, right? Something like this. So you will have to keep checking their extraocular muscle movement, how it is. Non-surgical, guys, non-surgical is very easy. You know what? Let's tell non-surgical. In non-surgical, guys, we have smoking cessation, head elevation, lubricating artificial eye drops, I think to prevent that exposure keratitis, right? Eyelid taping, you tape it. Guanethidine, prisms to avoid the diplopia, yes, and then systemic steroids, okay, radiotherapy, combined therapy. Any doubt if you have, we can look at them. Smoking cessation, who won't understand, tell them to stop smoking because it's self-limiting. It'll go away. If you smoke, it will be there for longer years. That's what they said, right? Head elevation at night. Okay, only at night you elevate the head because they're sleeping at night. Otherwise, the head is always elevated, right? In the morning if you're walking. Cold compress in the morning. Morning you do cold compress. Night if you keep the head elevated. Why? Basically, you want to reduce the edema. That's it. You want to reduce the periorbital edema. So always you keep your head elevated. All the edema will be less. Okay, then lubricating artificial eye drops. Why will you give that? Because you want to relieve the dry ocular surface. Eyelid taping, again same thing, to prevent exposure. Guanethidine eye drops. Why will you give guanethidine eye drops? Decrease the lid retraction by overaction of Muller muscle. Okay. So basically this overacting Muller muscle was doing lid retraction. So now you want to decrease the lid retraction which is being caused because of the overaction of the Muller muscle. So this is one thing that they mentioned as a medication, guanethidine. Prisms, why will you give prisms? To elevate, to remove the diplopia, which will be there till the inactive stage is really reached. Yes, please focus. What are we looking at? Management. In that management, we're looking at non-surgical. Very good. So now let us continue, guys. Steroids you will give. Why? To reduce inflammation. Okay. Radiotherapy you can give. 20,000 rads given over 10 days may help in reducing orbital edema. First time I'm seeing radiotherapy actually for this. I mean, otherwise we always hear this radiotherapy in cancer. Radiotherapy to reduce orbital edema. Combined therapy with low-dose steroids, azathioprine irradiation is more effective than steroids or radiotherapy alone. So instead of giving steroids and radiotherapy alone, here they are doing steroids plus radiotherapy. Combined is more effective, they are saying. Why will you give prism, guys? To reduce the diplopia. Okay, all these were non-surgical. Now we will go to surgical. Last thing that we have to read here is surgical. Surgical, there are three things that they have mentioned here. Orbital decompression, extraocular muscle surgery, eyelid surgery. Eyelid surgery we can understand. Okay, extraocular muscle also we can understand. Orbital decompression. What is orbital decompression? Let's look at that. So let us see, during active phase, orbital decompression may be required. See, actually what is happening is the orbit getting compressed. Is that what they are trying to say? Because it is getting compressed and the nerve is getting compressed, something like that. So they want to decompress it. So you want to decompress it how? Surgically. So how will you do that? Okay, they are telling during active phase, this thing, during quiescent burnout phase, you wanted to improve the function, you will do some surgery. Stepwise surgical focus, guys, how's it going? What are we looking at? Surgical, yes, of what? Thyroid eye disease, TED. Yes, what did we see in the surgical? We said to do orbital decompression. Okay, good. So let us look at the surgery. You start with the orbital decompression, follow by the extraocular muscle surgery, followed by the eyelid surgery. So first you try orbital decompression. What is that? 2-wall decompression, 3-wall decompression, 4-wall decompression. All the 4 walls you can decompress. At least 3 walls they are decompressing. 2 walls you can decompress. Choose what you want. 2, 3, 4. 2, 3, 4 are the decompressions. 2-wall means orbital floor and medial wall are removed. Allow for, wow, they are removing the orbital floor. Floor has become a part of the wall, is it? Interesting. So orbital floor and medial wall are removed. 3-wall means floor, medial wall and lateral wall. And 4-wall means they are removal of lateral half of roof and large portion of sphenoid at the apex. Okay. In addition to the 3-wall removal, they are also removing the lateral half of roof. First time roof got involved, right? Till now only floor was there. Now roof also they are talking about. Large portion of sphenoid at the apex. So all this they will remove, guys. Why in the orbit they will remove everything? Because they want to make way for all those extraocular muscles which are undergoing edema. They don't want compression because otherwise the nerve will get damaged. So that is about compression. Now let us move on to extraocular muscle. This should always be carried out after the orbital decompression. So then extraocular muscle surgery is in the form of recession is required to achieve binocular single vision. To get binocular single vision, what is binocular single vision now? Two eyes you will see, but you want to see only one image. So because those people had diplopia, right? They don't want two images. That's why. So extraocular muscle surgery. Inferior rectus recession is the most commonly performed surgery. Let's remember this one. Inferior rectus. Where is inferior rectus? If this is the eyeball, inferior rectus is here, right? Holding it. So the inferior rectus recession is the most common. Recession means what? It will go backwards, right? That is only recession, right? So you will cut the muscle and put it backwards. So that will make it weaker, right? So inferior rectus recession is most common performed surgery. If you remember this, the muscle is moved backwards. That is recession. That is going to make the muscle weak. So this is a very common thing if it is done for what? If it is done for inferior rectus recession is the most common performed surgery for what? Thyroid eye disease. Guys, where are we? We have finished in surgical. We have finished orbital decompression and extraocular muscle surgery. Now we have to move to eyelid surgery. What they are saying is eyelid surgery should be done only after the other two procedures. So it should be undertaken at last because all the other surgeries can affect the lid, etc. Okay. So here what are they talking? Botulinum toxin you will give so that you can relax the molars muscle which was overacting, right? So they are giving botulinum toxin, that botox thing which they use for beauty. Okay. So this botox will target what? Molar muscle and the LPS muscle. So whatever that upper eyelid, so this is eyeball means upper eyelid, you have two things, right? Molars muscle and LPS. So for that, to treat those two, they will give botulinum toxin. So both of them should relax and come down a little. What do you say? Mullarotomy, remove the molar muscle, is it? Disinsertion of molars muscle. Levator recession, disinsertion. For levator, is it? Then scleral grafts with LPS recession may be required in severe cases. In severe cases, scleral grafts with LPS recession. LPS recession means they have made it go backwards, the LPS. So LPS will not overact. Scleral grafts they are giving with that. Recession of lower eyelid retractors may be required. See, if there is lower eyelid also is what are we saying? Retracted. If lower eyelid is also retracted, then they will have to recess the lower eyelid retractor. Okay. Blepharoplasty. Some blepharoplasty means removal of excess fatty tissue and redundant skin from around the eyelids. Okay. So that's it about the surgical for eyelid. That's it, guys. We are done with all the things that we wanted to do for thyroid eye disease. Thyroid eye disease. We are done with all these topics. Let's take a recap. So let's start here. Thyroid eye disease, TED. Basically here there are three things you should know. Lid retraction, lid lag, proptosis will be there. The person will look like he's staring. He won't blink much. All these things are because of the thyroid. It's called as endocrine exophthalmos, malignant exophthalmos, etc., etc. Basically, the disease can be because of maybe associated with hyperthyroidism, euthyroidism. The thyroid hormones are not the cause. That is what you have to understand here. The thyroid hormones are not the cause. The antibodies are attacking both the thyroid and the eye because both of them have to have similar antigen or something. So these antibodies as an autoimmune process are attacking both. That is what they think it is. Okay. So these antibodies can be something that stimulate the thyroid gland, or they could be something that are anti-thyroid also. So it can be either hyper, hypo, or euthyroid. Okay. Then who are at risk? The female gender, the smokers, smokers. You remember? Okay, that is there everywhere actually. Smokers, middle age. So that is really bad. In the middle age also you can get some diseases like this: autoimmune thyroid disease and HLA-DR3, HLA-B8. Pathogenesis, basically the antibodies are attacking whom? The antibodies are attacking both the thyroid gland and the eye. First, the orbital fibroblasts are attacked. Then there is attack for the extraocular muscles. So there is going to be adipogenesis, fibroblast proliferation, and glycosaminoglycan synthesis. These are important. Okay. Then extraocular muscles are going to undergo edema. So all this will lead to what? Compression in the orbit. Orbit is getting compressed because of all these excess things that are there. So there will be some clinical signs like retraction of the upper eyelid, Dalrymple sign, then lid lag, von Graeffe's sign, fullness of the eyelid, difficult to avert the upper eyelid, infrequent blinking, all this conjunctival signs will be there. Pupillary signs, ocular motility will be difficult, Mobius sign, Exophthalmos will be there. Okay, usually it will be bilateral, it can be unilateral also. Exposure keratitis can be there because these people are not blinking, they are staring kind of a thing. Optic neuropathy because of all this compression. There is a classification, guys. We are revising, so please pay attention here. So there is no specs, that is initially no signs and symptoms, then lot of signs are there, then symptoms. Finally, there's loss at optic nerve involvement, that is 6. Class 6 is optic nerve involvement. Clinical course, it is self-limiting. In smokers, it can be long running. There is active phase and inactive phase. Active phase becomes inactive because of the middle, there is some regression. Okay. Clinical diagnosis, how will you diagnose? You will use, you'll order thyroid function test, you check for the antibodies, you will do ultrasound, you will do CT scan, MRI of the eye. Management, you can do periodic clinical workup, non-surgical, surgical, guys. Periodic clinical workup means you'll keep monitoring their pain, swelling, redness, loss of function. You'll keep checking their ocular motility with this Hess chart and all that. Non-surgical, you'll tell them don't smoke, head elevation, so to prevent edema, lubricating artificial teardrop to prevent the dryness, keratitis, exposure keratitis, eyelid taping, Guanethidine to relax that molar muscle, prisms to prevent the diplopia, systemic steroids, radiotherapy. Combined is the best with steroids and radiotherapy. So we saw non-surgical, guys. Then we moved on to surgical. 3 things only they're saying. First, you do orbital decompression. That if it is not working, then you follow it with what? This is orbital decompression. Yeah. Then extraocular muscle surgery. It should be done after the orbital decompression. Then eyelid surgery, which should be done after the extraocular muscle surgery. Okay. So that's it for now in thyroid eye disease. Bye bye.